2, 1. Over to you, sir.
Good morning, everyone. On behalf of Adley Oncology, I would like to welcome guest speaker of today's webinar, Dr. Rina Speck, Professor of Oncology, University of Copenhagen, Denmark. She will be speaking on total body irradiation in hematopoietic stem cell transplantation. I would also like to welcome chief guest of today's webinar, Dr. Francisco Couto, and our elite discussions, Dr. Joseph John, Dr. Dharma Chaudhary, Colonel Dr. Rajan Kapoor, Lieutenant Colonel Dr. Uday Yanamandra, Group Captain Dr. Harshit Khurana, Dr. N. Aditya Murli, Dr. Shubha Prakash Sanyal, Dr. Dipanjan Haldar, Dr. Srinath Shirsagar, Dr. Dipankar Bhattacharya, Dr. Mallikarjun Kalashetty, and Dr. Sanket Shah. Before we commence the event, I would like to brief you about current happenings in oncology in Adelaide through a short corporate video. So Roshni, can you please run the video, please? Thank you, Roshni. I just like to inform you that Carfilzomab, our brand Carfimab 60 mg injection, will be available from tomorrow onwards for all Indian patients. Adley is now into the forefront of providing novel molecules of highest quality for all the Indian patients at affordable cost. Now to commence the event, I would like to invite architect of this academic feast, teacher of teachers, Professor Dr. M.B. Agrawal, sir, please. Thank you.
Thank you, Mr. Ashutosh. Good morning to one and all. Today we have the lecture on total body irradiation in hematopoietic stem cell transplantation, current status and future directions by none other than Dr. Rina Speck from Denmark. This webinar is brought to you by Mumbai Hematology Group. It is supported by Adley and managed by Mice Ideas. Next weekend, Saturday evening, 7 o'clock, we have Dr. Lewis from Houston, who is going to speak to us on T-cell lymphomas. And next Sunday morning, 11:30 a.m., we have Dr. Poilo from Milano, going to speak to us about venous thrombosis at rare sites. I thank Mr. Ashutosh Shukla and the team Adley for supporting our academic activities. Mr. Rajesh Kalpesh and their team from Mice Ideas for managing the shows flawlessly. Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Francisco Couto from Goa. Our guest speaker, Dr. Lena Speck from Denmark. All our discussants who are themselves eminent hematologists, medical oncologists, or bone marrow transplanters. And you participants for sparing your Sunday morning from almost 14 to 15 countries. We have over 350 registrations today. Now it's my pleasure to introduce my friend and the chief guest of the day, Dr. Francisco Couto, MD, FIC Path from Goa. He's director, professor of pathology at the prestigious Goa Medical College, vice president for Asia International Academy of Pathology, IAP. Member, Education Committee, IAP. Counselor, IAP. Member, International Executive Council of IAP. Member, Executive Council of Asia Pacific Assembly of IAP Divisions. President, International Academy of Pathology, Indian Division, 2009-10. Secretary and Treasurer of IAP ID 97 to 2008. Editor, IAP ID Newsletter 97 to 2008. Advisor, IAP ID from 2011 till date. Dean 2002 to Indian College of Pathologists. Secretary, ICP 2013 to 18. Member, Executive Council, ICP 2019 to 21. President, Goa Association of Pathologists from 16 till date, and Treasurer of the same group from 2004 to 15. Secretary, Indian Medical Association, Goa State, 2015. President, IMA Tiswadi Branch, 13 and 14, and Secretary, IMA Tiswadi Branch, 11 and 12. Awarded International Academy of Pathology Gold Medal in 2016. Awarded Special Honor Medal of the Armed Forces Institute of Pathology. Awarded 60th Anniversary Special Award of the Japanese Division of IAP 2021. So now it's my pleasure to invite him to give some words of wisdom for our colleagues and inaugurate today's webinar. Thank you.
Thank you, sir, Dr. M.V. Agarwal, for that very warm and lavish introduction. Dignitaries of this webinar, Dr. M.V. Agarwal, President of the Mumbai Hematology Group, eminent guest speaker, Dr. Lena Spech, faculty discussants, office bearers, and members of the Mumbai Hematology Group, delegates and friends. I am indeed privileged and deeply honored to have been asked to be the chief guest for today's live webinar conducted under the aegis of the Mumbai Hematology Group. Dr. M.B. Agarwal, the doyen of hematology in India, an eminent hematologist and hemato-oncologist, is a well-known, brilliant teacher and clinician, as well as is well-known for organizing exceptionally good conferences, CMEs, workshops, and webinars of the highest quality with distinguished national and international speakers in different fora. The Mumbai Hematology Group has been at the forefront in organizing and conducting top quality academic programs, which have been a boon to physicians and pathologists alike who are interested in hematology. Our deepest appreciation, thanks, and congratulations are due to Dr. M.B. Agarwal and the Mumbai Hematology Group for organizing and conducting this high quality academic programs, which are done on a very regular basis. The topic for today's webinar, Total Body Irradiation in Haematopoietic Stem Cell Transplantation, Current Status and Future Directions, is very apt and promises to be a rich learning experience and will be ably dealt with by a renowned speaker for today, Professor Dr. Lena Spech, who I'm sure will enrich our knowledge on the subject with a vast experience and expertise, and will be ably supported by very useful inputs from a distinguished panel of discussants who will contribute their own experiences and knowledge to the subject. Hematology as a discipline has made tremendous strides in the last several years and is now an important specialty of its own, having evolved from being a part of general medicine, pediatrics, or pathology. For the younger doctors attending this webinar, hematology provides a fascinating and fulfilling avenue for quality work, both clinical and laboratory based, as well as opportunities for research, and would provide a bright and highly satisfying future career. Blood being the dynamic, life-giving fluid that it is, any changes in it can cause effects ranging from mild to profound, like from simple things like iron deficiency anemia to life-threatening disorders like leukemias. A correct diagnosis and appropriate treatment has a profound effect both on the morbidity and mortality of patients. And it is a very satisfying and fulfilling experience to the hematologist that his or her intervention help alleviate and mitigate the patient's suffering and disorder. So, for the younger doctors interested in hematology, do not be afraid of pursuing hematology as a career, as it will be a very rewarding and fascinating journey in your professional life. I'm sure that today's webinar will enrich our knowledge and be a wonderful learning experience to all attending it, and also provide a forum for the exchange of ideas and information, which will help us in our hematology practice. I'm now happy and honored to inaugurate this webinar, and I wish this webinar great success and very fruitful deliberations. Thank you.
Thank you so much, Dr. Francisco Coito, for those very kind words.
Thank you, sir.
Everybody who is listening knows Dr. Coito extremely well. He's been a torchbearer of hematopathology in the neighboring state of Goa. And I'm sure that all of you have enjoyed your vacations on the beaches of that wonderful state of India. And Dr. Lena probably will be your guest one day and enjoy the beach life there. And now
I hope so, yeah.
I'll share my screen to conduct the Sunday quiz for the day. As you know, we have this quiz every Sunday for the postgraduates and others. Today, you will be shown 3 pictures. All these 3 individuals have same hematological malignancy, and they are on treatment with the same drug. You have to look at these 3 pictures of 3 individuals, and you have to name the drug on which they are. And you have to email the name of the drug to mbagarwal1@gmail.com. So I'm sure you got it. We will show you clinical picture of 3 individuals having same hematological cancer. They are receiving same drug, and the picture will tell you what drug they may be on, and you have to name that drug and email the name of that drug, and the winner will be fastest finger first. These are those 3 pictures. 3 separate individuals, same disease, on a drug, and the name of the drug can be guessed from looking at these 3 pictures. Okay. So send your answer by email to mbagarwal1@gmail.com. Winner will be the fastest finger first. Now we move on to the case of the week. As you know that we bring out some unusual cases every week and present to you, mainly a great experience for the junior colleagues. Now today's case is VKL, aged 27 years, diagnosed to have T-cell acute lymphoblastic leukemia. He was put on hyper-CVAD therapy, after which he had prolonged severe neutropenia with absolute neutrophil count of 0 for quite some time. Therefore, he was on GCSF, multiple antibiotics, antifungals, blood products, and other support therapy. He was infected, and his culture grew Pseudomonas and E. coli, and the antibiotics were adjusted as per the report. However, his fever worsened, and he developed certain skin lesions, which we are going to show you. And this is one of the lesions on the dorsum of his hand, wrist, and the distal forearm. And this is not something very old. It spread to this dimension within about 3 days. He recovered from neutropenia. However, his high-grade swinging fever did not settle. Further, blood cultures were negative, and continuous changing or adding antibiotics and antifungal agents did not help. He developed marked neutrophilic leukocytosis, and his absolute neutrophil count went up to 28,000, and there were few band cells. C-reactive protein was extremely high. Smear and culture from the skin lesions also did not show anything different. A diagnosis was thought of. Investigations were done to pursue that diagnosis. The diagnosis was confirmed and a treatment was carried out according to that diagnosis, and it was successful. His fever vanished, the neutrophilic leukocytosis came down, and the CRP came down. Patient was discharged and the skin lesions healed over next 3 weeks. Which diagnosis was thought of? This is not a quiz, so you don't have to write any answer. This is going to be, the answer will be told to you just now, but you can think something in your mind. Which diagnosis was thought of? How was the diagnosis proven? And how was that particular entity treated? So the diagnosis was thought of was Sweet syndrome. And those who are our junior colleagues in the audience might not have seen a case of Sweet syndrome because it is not an entity which you see every day in your wards. Sweet syndrome is another term for what was originally called acute febrile neutrophilic dermatosis. Sudden onset, febrile patient, some skin lesion with neutrophilic infiltration is the explanation for this term. Now, the test done was a skin biopsy. You can see the epidermis at the top and the dermal infiltrate at the bottom. Massive infiltration by neutrophils all over. Little closer view, little dull picture, but you may be able to appreciate the bluish neutrophilic infiltration, which you can best appreciate over here. You can see neutrophils all around in the dermis. Just one slide to tell you about Sweet syndrome. Sweet syndrome is not that sweet for the patient or doctor. Sweet syndrome is called so because Dr. Robert Douglas Sweet first described and used the term acute febrile neutrophilic dermatosis way back in 1964, based on his observations in 8 women. Subsequently, others called it Sweet syndrome after Dr. Robert Sweet, and that has got established as an eponym for the acute febrile neutrophilic dermatosis and has been used worldwide. The 3 major subtypes: drug-induced, malignancy-associated, and idiopathic. All 3 of these share the same presenting scenario of abrupt onset of skin lesions. And I'm not describing the skin lesions because anything can happen. It is in the setting of fever. It is in the setting of leukocytosis. And if you do the histology, you will find dense neutrophilic infiltration of the dermis without any evidence of vasculitis, as I just showed you. The most successful treatment is indomethacin, colchicine, and corticosteroids. Our patient was put on indomethacin, 150 mg per day, which is the recommended dose, together with colchicine, 1.5 mg, which is the recommended dose. And after a couple of days, he was also given a small dose of steroid when we became confident that he is not infected. We could start tapering these drugs from the 2nd week onwards as the patient settled. So that was Sweet syndrome for you. And now the main part of the webinar today, our guest lecture on total body irradiation in hematopoietic stem cell transplantation, current status and future directions. My pleasure to introduce our regular speaker, Dr. Lena Speck from Denmark. She was with us in Mumbai. She has been doing regular webinars for us during the last 2 years. I'm extremely grateful to you. These have been very, very early mornings for her, but she has always obliged us. Our discussants today are very, very important personalities from India. Dr. Joseph John from Christian Medical College, Ludhiana. Dr. Dharma Chaudhary from BLK Super Speciality Hospital, New Delhi. Colonel Dr. Rajan Kapoor from Command Hospital, Eastern Command, Kolkata. Lieutenant Colonel Dr. Uday from AFMC, Pune. Group Captain Dr. Harshit Khurana from Command Hospital, Southern Command, Pune. Dr. Aditya Murli from Esther CMI Hospital, Bangalore. Dr. Subhaprakash Sanyal from Fortis Group of Hospitals, Mumbai. Dr. Deepanjan Halda from Jupiter Hospital, Thane, Mumbai. Dr. Deepanka Bhattacharya from Vedanta Hospital, Lucknow. Dr. Mallikarjun Kalashetty from Comprehensive Cancer Center, Manipal Hospital, Bangalore. Dr. Sanket Shah from HOC Vedanta, Ahmedabad. And now it's time to introduce our speaker herself. Dr. Lena Speck is Professor of Oncology at the University in Denmark since 2009 in Copenhagen. She completed her training in clinical oncology at the University Hospital in Copenhagen. She held a research fellowship for 3 years at the Danish Cancer Society. She obtained her PhD degree for the work on prognostic factors in Hodgkin lymphoma. The chief oncologist, the departments of oncology and hematology, the University of Copenhagen since 2001. Her main areas of research and clinical interest are lymphomas and head and neck cancer. She's the author of over 300 research articles and educational papers, including ESMO guidelines on peripheral T-cell lymphoma and cutaneous lymphomas. She authored 3 textbooks, 27 book chapters, and over 500 oral presentations and posters at national and international meetings, 180 invited international lectures, H-Index 66. She has supervised 18 PhD projects and numerous postdoc, postgraduate, and pre-graduate projects. She's editor of the Cochrane Hematological Malignancies Group and a member of the advisory board for Acta Oncologica. She's chairman of the Danish Hodgkin Lymphoma Group and vice president of the International Lymphoma Radiation Oncology Group. She's received numerous awards. Some of them include the Oncology Award, Danish Society of Oncology 2004, Bunch Jensen Founder Prize 2010, Global Excellence in Health 2014, and again in 2010 and again in 2014. So that's a brief introduction of our very learned guest speaker. I'll stop here and request her to deliver her lecture.
Thank you very much. And I will share my screen now. And thank you very much for that kind introduction, and thank you for the invitation, and greetings from Copenhagen, where spring is just starting, but we still have night frost, which I don't think you will have in India by this time. But we're going to talk about total body irradiation in hematology.
You can put it in the slideshow mode.
Can you see my screen?
We can see your screen, but it's not in slideshow mode.
Oh, my screen is on slideshow. I think you just have to wait a moment.
Okay.
Is the technical person able to help?
Roshni?
Ma'am, please stop share your screen and then share it again.
Well, that's my stop share. Okay. Yeah, and then share again.
Yes.
And then I'll find my presentation because, well, there it is. How about it now?
Yes, perfect.
Good. Thank you. Well, I'm going to talk about total body irradiation in hematopoietic stem cell transplant because new things have been happening here. And how do I change my slide? Anyway, like this. These are my disclosures. Now, total body irradiation is used in 2 ways. It's used as high-dose total body irradiation, where we normally give it at doses of about 12 to 14 gray to the whole body. And this is used for conventional myoablative conditioning. Before allogeneic transplantation, in that situation, we use the total body irradiation both for tumor cell kill, but also importantly for immunosuppression to avoid rejection of the donor marrow. In some cases, in rare diseases, we also use the total body irradiation for killing genetically defective cell populations. For autologous transplantation, of course, the main reason we're using TBI is tumor cell kill, and it's actually not often used in autologous stem cell transplants. But another important use is for low dose, for reduced intensity conditioning regimens, where we only give 2 to 4 gray total body irradiation. And we use this for the mini allo transplantations, and the main reason for using it is to achieve immune suppression to avoid rejection of the donor marrow. Now, the indications for conventional allogeneic or autologous transplantation with TBI is, as you very well known, for first and foremost the acute leukemias, ALL, AML, also CML sometimes, and for lymphomas or other myeloproliferative diseases, lymphomas both Hodgkin and non-Hodgkin, but only if patients have had minimal previous irradiation, also for myelodysplasia, and then for immunologic diseases such as aplastic anemia, and for the rare genetic diseases like Wiskott-Aldrich syndrome and Fanconi anemia and others. But at least in my practice, the acute leukemias are the main indication. The reduced intensity conditioning allogeneic transplantations are really a different kind of treatment. It's an immune treatment exploiting the graft versus lymphoma or leukemia effect of the donor marrow. And it can be used in older patients and patients with comorbidities who would not tolerate a myeloablative regimen. It is used quite extensively in my institution in high-risk acute leukemias, lymphomas, myelodysplasias, aplastic anemias, and others. And in a large hematology department with third referral unit like mine, we do far more reduced intensity allogeneic transplants than we do the myeloablative ones. The advantages of using total body irradiation as part of conditioning are several. First of all, there is no sanctuary. There are no parts of the body that are protected from the treatment, such as, from systemic chemotherapy, testes, CNS, and skin. No organ is protected from the treatment. And we can achieve a homogeneous dose distribution independent of blood supply. So all areas of the body are reached. There's no cross resistance with other drugs, and we do not need to do dose modification with reduced organ function as opposed to chemotherapy, where you will have to take into account the degradation and excretion of the drugs in the liver and the kidneys. And the dose distribution in the body can be modified by blocking or boosting, and that in particular has become much more refined with the modern radiotherapy techniques. The indications that we're using a TBI for are, as I mentioned, conventional allogeneic transplantation, where most regimens contain total body irradiation. An alternative is busulfane containing regimens, which can be used in patients who will not tolerate total body irradiation, for example, patients who have had a lot of radiation before. For autologous transplantations, some regimens contain total body irradiation, but at least in my institution, we really have no regimens at this point in time where we're using TBI in autologous transplants. And then for the reduced intensity conditioning allogeneic transplantations, all regimens contain total body irradiation, but of course to much lower doses. And the total body irradiation was, of course, introduced with the introduction of bone marrow transplantations, and each institution developed their own method of doing it. And here you can see just some of the very varied solutions that have been developed in the big institutions around the world. Clearly methods that had been devised locally, and where the patient was positioned in different ways, like standing or sitting or lying on the side and so on. And common to all these are that the patient is treated at a longer distance from the accelerator to achieve a large treatment field where the whole body can be covered, and that the patient's position and the whole setup, of course, completely precludes any three-dimensional planning. In fact, this is how you did radiation therapy quite a long time ago. Patients were planned simply by measuring their thickest point, and then the doses were calculated accordingly. There was no three-dimensional planning based on CT scans that we will normally today do for all modern radiation therapies. And this field has been rather special, and I've been in it a long time. And the problem has, in a way, been that the transplanters are not familiar with radiotherapy as such, but they always wanted you to not change anything. They were very conservative because they feared that things could go wrong if anything was changed. So even the most prestigious institutions around the world still had these really primitive ways of doing this treatment. However, these treatments were in many ways, and they are still used in many places, based, as I said, on two-dimensional planning, very primitive, simply measuring how thick the patients were, thickest in the thickest part, and then calculating at treatment, which was very inhomogeneous dose distribution and largely unknown. And you could easily, if you tested it, see that some areas got less than 80% of the prescribed dose, and some areas actually got more than 120% of the prescribed dose. And really, we did not have much certainty about the dose prescription at all. They were given at an extended distance from the accelerator, as mentioned, in order to have the whole body in the field. And this means that the treatments were given with a low dose rate. Now, a low dose rate is actually an advantage because it protects the normal tissues. And this was another reason why transplanters were very reluctant for us to change technique, because they feared more side effects if closer or less extended distances were used, and then the dose rate would go up. And I, in fact, I was also quite scared to change that. But as times went by, we really did see that we needed to change, and we needed to take also total body irradiation into the modern era of much more precise and controlled radiation therapy. So in the International Lymphoma Radiation Oncology Group, we have developed guidelines on many issues in hematological malignancies radiotherapy, and we developed guidelines on total body irradiation to hopefully be instrumental in taking total body irradiation also into the modern era of radiotherapy. And they've been published in what your radiation oncologists will know as the Red Journal, and just for your reference, you've got it here. Because change was and is needed in the places who still use the two-dimensional techniques, because the modern highly conformal techniques offer better options to shield organs at risk without compromising the anti-leukemic and immunosuppressive effects. It gives much better dose homogeneity, making sure that we get the same dose in all parts of the body. And we are increasingly able to shield critical normal tissues without blocking bone marrow compartments. And we will have much more consistency in total dose rate, fraction size, and overall treatment time. We at my institution also use two-dimensional planning up until about 5 years ago. And then we really had to tell our transplanters we do need to change it. The equipment was so old-fashioned that we couldn't support it anymore. And we traveled actually to many large institutions to see what techniques they were using. Many of them were actually using very old-fashioned techniques like our own. But we tried to find the technique that was best suited for a large transplant center like ours. and which would give us the advantages of modern radiation therapy. And the technique that we implemented, I'd like to tell you in a little more detail, because we are very satisfied with it, and because it is also, I think, a technique that might be interesting to many of your institutions, because it uses a completely ordinary linear accelerator. You need no very highly costly and special equipment to do this. This was a technique that was originally devised at the Royal Marsden Hospital in London. And then we also implemented it, and we worked together with the people at Royal Marsden to make some refinements and modifications of the technique. And we have published the technique in this article, which again, for reference for your radiation centers, was published in what is called the Technical Innovations and Patient Support in Radiation Oncology, TIPS-RO as it's called. And the idea with this treatment is that we are using still extended field, extended distance treatments, so that we achieve the low dose rate that protects normal tissues. And it is delivered as a number of different fields delivered. Field 1 is delivered to the entire body. Then there's a field protecting the oral cavity. Then there are, and these are individually devised for each patient. Fields 3 and 4 are boost fields that protect the areas around the lungs, and field 5 and 6 are, field 5 is a boost area also around the lungs and all the other critical structures, and then field 6 is a setup field that ensures that we get the setup right. We deliver these a number of fields, often 7, 8, 9 different fields from one side, and then we turn the patient around and give similar fields from the opposite side. So by doing this, this is what, for radiation oncology, is sort of a modified intensity modulated radiotherapy with a step and shoot technique, where we give treatment on static fields, but together these fields will give you a intensity modulated radiotherapy of the whole body. And what we do is that we do a CT scan of the whole body with the patient in the treatment position. The treatment position is secured with fixation equipment. And so as for any other modern radiation therapy, we use a CT scan of the target area, and the target area being the whole body. We need to have a whole body CT scan, which we do in our ordinary planning CT scanner. And then we take the total body CT scan into our treatment planning system and make a treatment plan based on these different treatment fields from both sides of the patient. And you can see here a treatment plan in colors, a color wash treatment plan, where the hottest areas are the red ones, and we can, with this technique, keep our treatment dose within plus or minus 10% of the prescribed dose. So the red areas are the hot areas where the dose is about 110% of the prescribed dose, and then we move over yellow, green, and blue to the coolest areas that get about 90% of the prescribed dose. And that is a much better dose homogeneity than you would ever achieve with any of the old-fashioned techniques. So we are able to keep the dose in the whole body within plus minus 10% of the prescribed dose. And we are also to some extent able to determine where in the body we are at the low and the high end. And as you can see here in the lungs here, we are in the lower end of the dose spectrum, in the blue area, where the dose is about minus 10% of the prescribed dose. And our dose planners and physicists have become so good at this that we always get extremely good plans on these patients. And we use the ordinary treatment planning system that is used in the ordinary. We are a varying clinic, so it's the ordinary dose planning system. We use a beam spoiler because one of the problems in total body irradiation is to get a sufficient skin dose, and that is simply a perspex plate mounted on the couch of the patient. The plans are based on these template fields that I showed you previously, and the plans are made by our dose planners or physicists and checked by our physicists. And as you can see here, this is a slice of the treatment plan. The lungs are kept in the lower end of the dose spectrum, does get the dose prescription, but at the lowest end to decrease the risk of pneumonitis. The kidneys are the third most sensitive organ to total body irradiation. So we also, this is the top of one of the kidneys, and we actually also keep them in the blue area, the low dose, lowest part of the dose spectrum. And then when the patient comes for the treatment, the patient is positioned 3.5 meters from the radiation source. This is something that has to be modified locally, and this is the largest distance we can get in our rooms. We have to make absolutely certain that the patient is positioned in the right distance. So you can see we have a laser light here that needs to go through the middle of the patient. And the beam spoiler, you can't really see it, but it's mounted here on the couch. And as a last precaution before we start, we use the setup field here in the multi-leaf collimator of the machine. We then, the patient will be lying here 3.5 meters from the machine, and you can see the multi-leaf collimator here with the lights. What we do is that with this setup field, we lower the couch of the patient, and then we check that the shadows on the wall fit with the setup field to make absolutely certain that we have the right position of the patient. Then the couch is moved back to the treatment position again, and we're ready for treatment. And besides the large fields encompassing the whole body, you can see one of these supplementary fields here. This is a supplementary field where we use the multi-leaves to cover the lung area. And this is how we can keep the dose to the lungs at the lower end of the dose spectrum. We use a low dose rate. Not only is the patient positioned for quite some distance from the machine, but we also use a fairly low dose rate from our machine in order to get this low dose rate that will protect the normal tissues for toxicity. Our standard is that for high dose total body irradiation for the myeloablative cases, we use a total dose of 12 grays given in 6 fractions over 3 days, with at least 6 hours between fractions. That is a very standard treatment regimen for myeloablative total body irradiation all over the world. For the reduced intensity conditioning TBIs, we use either 2 or 3 gray given in just 1 fraction. And each treatment, when we're giving about 2 gray, it will take about 20 minutes to give the treatment from one side. Then we turn the patient around and give the same or the corresponding field from the other side. It takes another 20 minutes, but usually the treatment time for a patient will be for an hour for each fraction. Now, the reason that I recommended, I went into detail with this, is that, as you can see, we used no devices that were any special. We used the ordinary technology that we are using in our daily practice, and that your radiation oncologists will use in your daily practice. That is an ordinary planning CT scanner, an ordinary dose planning system, and an ordinary accelerator for treatment. But there are many other techniques devised. This one still uses extended distance to the patient, but uses what we call volumetric arc treatment, where the accelerator actually rotates in an arc around the patient. And again, here you're able to achieve very nice dose plans with very homogeneous plans and well, some sparing perhaps of some of the normal tissues. This technique again allows you to modify the beam so that the dose homogeneity becomes as modern standards. But the temptation is, of course, to use the modern techniques in full, with the patient not positioned far away from the accelerator, but positioned like we normally treat patients, on the couch, just 1 meter from the source. This means that the dose rate will be much higher, and there's been some, of course, reluctance, and also some considerations whether this was safe or not. It has been done now in many institutions around the world, but it's still something that we need to be aware of and to check. But so far, there have been really no signs of any detrimental effect of this when we are using the fractionated treatment that we're using now. And this is one of the possibilities if you have a tomotherapy unit. A tomotherapy unit is a machine where the patient is irradiated with a very narrow band of X-rays, and then the patient is moved through the machine just as if it were a CT scanner. So the treatment is given in narrow bands consecutively through the patient. It does take some time with these large treatment areas, but with this technique, we can use the modern techniques full out and do dose plans where we protect the lungs and the kidneys selectively without decreasing the dose to the surrounding parts of the body. And you can see a very nice dose plan achieved with helical tomotherapy. And most institutions like ours, we do not have a tomotherapy machine. We don't really see that we need it. But here is the possibilities you have with an ordinary LINAC. And an ordinary LINAC, that is the ordinary treatment machine, using the volumetric arc therapy, which most of us use today, which is the modern way of doing radiotherapy in general. But if you want to use that technique, and that is a technique where the treatment machine moves around the patient, so that you treat while the machine is moving, and at the same time the multi-leaves or the multi-leaf collimator move to achieve intensity modulation. That gives you a lot of freedom to decide exactly which dose you want in each part of the body. But if you want to do total body irradiation with this technique, you will have to do it in sections. And you can see here, this is an example here where they have 6 different sections. In many cases, maybe up to 9 sections, depending on how tall the patient is. And when you do this, there are, of course, a number of problems because you are actually combining this treatment from different treatments that have to be combined. The patient is lying on the couch, and you will then irradiate separate sections at a time. And because the machine and the couch isn't that long, you will have to take the upper part of the body with the patient with the head first position, and then you will have to rotate 180 degrees and take the lower part of the body with the feet first position. So there are some complications and technical problems here. Problems with these treatments where you are treating with the patient close to the machine, like you would do in normal radiotherapy, is first of all that you do have a higher dose rate. We don't know whether it matters today, where we're giving fractionated total body irradiation. We do know that we have problems with overlap or underdosing at field junction. It can be quite complicated to achieve about the same dose in the areas where the different treatment fields are abutting. And there has also been the debate on whether circulating tumor cells could actually totally avoid being irradiated when you are giving the treatment in different sections. Now, for that fear, which was, of course, an important one, I think that it hasn't really materialized. We haven't seen signs of poorer leukemia control with even when we're giving the treatment in different sections. And that is probably because at the time when the patient comes for TBI, the number of tumor cells, the load of leukemia cells is very, very low. So the risk of a leukemia cell actually circulating and avoiding treatment at all sections is really perhaps very theoretical, but it has to be considered. But if we are using these techniques, then we have even more possibilities of refining our treatment. And at certain institutions, in particular in City of Hope in the United States, they have experimented with doing even more selective total body irradiations, or rather selecting the parts of the body that really need the treatment. And they have, by doing this, been able to do what is called total marrow irradiation. I mean, we can do that with our machines, all of us. It is quite complicated because you have to define the whole bone marrow as the target, and then the treatment planning system will be able to give you a treatment plan where only the bone marrow, the marrow containing bones, get the full dose. And when going into these highly refined techniques where you're actually selecting out the parts of the body that are going to have the full dose, then you also have to consider what is actually the target for our treatment. And my concern has always been that it is actually not the total marrow alone, because for the immunosuppressive effect of total body irradiation, we also need to irradiate the lymphatic system with the immune cells. And in fact, what they're doing at City of Hope is not really total marrow irradiation, but total marrow and lymphoid irradiation. For this, you need to define in the body not only all the bones containing the active bone marrow, but also all the major lymph node areas, as you can see here. It is quite laborious. However, the modern technology are helping us here. It would take hours for a physician to contour all the target volumes here, but we are in the process, and we are working on that actually in my group, on using artificial intelligence and machine learning to get algorithms and methods for our treatment planning systems to automatically contour these complicated targets, and then just have the human beings supervising the results of it. So it becomes more and more possible to make these complicated treatments, and for instance, to do total marrow and lymphoid irradiation. And this has been published. I just had the references here. I think we still have to regard this as experimental treatment because we don't know the long-term consequences of this, but it does enable you to give the treatment, the irradiating the marrow and the lymphoid system with only lower doses to the rest of the body, and it gives less toxicity, and it is a possibility for patients who would not normally tolerate high dose total body irradiation as conditioning regimens. So for the future in use of these new techniques, this will enable us in many ways to achieve less toxicity and to individualize shielding also of other normal tissues, like areas where this patient has comorbidities that would preclude using just ordinary total body irradiation. And also by protecting the critical normal structures and keeping the dose of them at a lower level, dose escalation would also be perhaps a possibility that could be pursued for total body radiation, which might in some situations perhaps offer some benefit, but that is a very demanding area of research, of course, because we cannot know a priori. But to do all this, we need to have comparable total body irradiation schedules around the different institutions doing this, so that we are able to compare our treatments and our results and combine our results, because these are there are not a lot of these patients and they're very diverse, so they're difficult to compare. We need to develop uniform specifications for our treatment and to have comprehensive standardized reporting of all parameters, so that we can develop in helping each other develop these techniques, and it does require cooperation between the large treatment centers and research groups. Now, these were all the technologies that are opening up new possibilities for giving total body irradiation in the most protective way that we can. There are other issues that are really important. Dose and fractionation are really important when you get into total body irradiation. The normal haematopoietic cells are highly radiosensitive. Leukemic cells are also generally highly radiosensitive, but there is more variation than in the normal counterparts. There is little repair of radiation damage in normal haematopoietic cells, which means that they are not very sensitive to whether you give high or low doses per fraction. They get about the same biologically effective dose, whether you give it in few or many fractions. There is, in fact, it turns out there is more variable repair in leukemic cells, and therefore greater variation in sensitivity to dose per fraction and to the dose rate that we're giving these patients. And a larger dose per fraction and or increased dose rate, that means giving a higher dose per minute from the machine, that will counter recovery of leukemic cells between fractions. So that could be a good thing, but it will also increase the damage to other normal tissues, most of which are very sensitive to fractionation changes and have quite significant repair between fractions if the doses are not too high. So this has to be done with great care and taking all other factors into account. And unfortunately, except for a few rare genetic disorders, there are so far no genotypic characteristics that we can use that will tell us how to modify the radiotherapy prescription to deal with the particular tumor cells. So we don't have any guidance in that so far, at least. Historically, in the beginning, when bone marrow transplantation was done, that single fractions of total body irradiation up to 10 gray was used, but the acute and late effects were quite severe. They did use a lower dose rate, and it was shown that the lower the dose rate, the better the therapeutic ratio and the better sparing of the normal tissues. But it meant that for single dose treatments, the patients would often have to lie for over 10 hours, which was really problematic treatment to give. And single fraction TBI has been abandoned. I don't know anywhere where they've done that for many years. Today, we give fractionated treatment, and the treatment schedule that we use, 12 gray in 6 fractions given over 3, or can be given over 6 days, has emerged as an effective and tolerable regimen, which is used in many institutions around the world. We do know that if you give higher fractions size, if you give the 12 gray just in 3 fractions, so 4 gray per fraction over 3 days, then we have increased acute effects. It turns out, and this is really important for using the modern techniques with the shorter distance to the machine, that the dose rate is less important when you give fractionated total body irradiation. So it's not so important as it was in the old days when the single fractions were used. So that leaves us some room for using the shorter distance in total body irradiation. We have looked at this in our institution. We gave 12 gray in 3 fractions for a long time. We have many patients for transplants, so it would mean quite an extra burden on our department if we were to double the number of fractions. So there was some reluctancy. But in the end, we got to change from 3 fractions to 6 fractions, thus halving the size of each fraction. And we could show that this change, which happened at a certain point in time in 2012, and there were no other significant changes in the treatment of these patients, the myeloablative patients in our institution. So we could see what happened to patients before and after the change from 3 to 6 fraction. And what we could show was actually surprisingly clear, because we saw that the median mucositis score went from 2 to 1 when we gave 6 fractions instead of 3. The mean cumulative dose of IV morphine diminished from 766 milligrams to 287 milligrams. The enteral nutrition was maintained for a median of 13 days with the 3 fraction regimen, and it went up to 21 days with the 6 fraction regimen. Parenteral nutrition was used for a median of 13 days with the 3 fractions and only 9.5 days with the 6 fractions. And the median total number of inpatient days after total body irradiation changed from 28 days with the 3 fraction regimens to 24 days with the 6 fraction regimen. And here you can see the daily median mucositis score after the graft infusion. This is day 0, and the blue curve is with the 3 fraction regimen, and the red curve is with the 6 fraction regimen. So a very clear improvement on all parameters of the mucositis that the patient experiences after total body irradiation. So that seemed an extremely good idea. But there are many other toxicities, and that is, of course, what worries us all with these very tough treatments, and a lot of different toxicities from all different organ systems with total body irradiation. The lung is the most frequent organ affected, and it is really extremely important organ here. Interstitial pneumonitis is seen, and on the longer scale, restrictive or obstructive fibrosis. The kidneys are also important with chronic renal disease, but then you see long-term complications from total body irradiation in virtually all other organ systems. What you need to remember is that if we cut out total body irradiation, you will have to give something else. And it increasingly turns out that that has also serious long-term side effects. So it is really a question on how we achieve our goal with the least possible total amount of long-term chronic toxicities. We looked at the lung function in our institution because, as I mentioned, we went from 3 fractions to 6 fractions in 2012. And then a couple of years later, we went from the old-fashioned 2-dimensional planning technique to our modern 3-dimensional technique that I showed you previously, with a much better homogeneity and sparing of some of the normal organs. So we had kind of 3 groups. We had a group that were treated with 3 fractions and with the old-fashioned planning. We had a group that got to 6 fractions, but still the old-fashioned planning. And then we had the newest group, which had 6 fractions and the modern 3-dimensional planning. So group 1, 2, and 3. And in that period, the conditioning regimens for the patients getting this treatment changed very little, but obviously there's always the risk of bias because, for instance, supportive care and other measures may well, in fact, hopefully have improved during that treatment. But we looked at the lung function, and this was done by a Chinese doctor visiting us, and will be presented at the upcoming ESTRO meeting here in Copenhagen, because this was really very interesting. We looked at the lung function tests, which these patients had before 3 months, 6 months, and 12 months after the transplant. And what you can see here is that the forced expiratory volume and the FVC measures of the obstructive lung function had very little change during the treatment. What really changed was the diffusion capacity, the DLCO, so the restrictive part of the lung function. And you can see that that part went down during and after treatment. And when we then looked at the measures in these 3 different groups, group 1 with the old-fashioned fractionation, the old-fashioned technique, group 2 with the new fractionation, but the old-fashioned technique, and group 3 with the new fractionation and the modern technique. You can see that, and you should overlook the blue one, which is just all of them, that again, the obstructive measures changed very little, but the diffusion capacity changed significantly. And what you could see is that with the old-fashioned fractionation and the old-fashioned technique, the diffusion capacity went down quite dramatically after treatment, and it kept becoming poorer and poorer, even up to 12 months after the transplant, and we really didn't get to see any improvement. The group number 2 with the modern fractionation, but still old-fashioned technique, showed somewhat less decline in the diffusion capacity, and significantly there was some improvement after 6 months, so that at the 12 months after transplant, the results seemed to be approaching but not reaching the original value. Whereas for the patients, the most modern group of patients treated with modern fractionation and modern three-dimensional technique, the decline was smaller, and the repair was better, so that at the 12 months point in time, these patients had reached almost the same value that they had originally. So to us, this really does demonstrate that both fractionation and technique are very significant factors that could be optimized probably in many institutions. And at least we were very happy that we could see some objective results of the refinements we've made in the treatment. So the question has been and should be always, do we really need total body irradiation as part of the conditioning regimen for hematopoietic stem cell transplantation? And this question is a burning one. And in particular, I must say for the children that we treat with the myeloablative regimens for recurrences or high-risk acute leukemias, because we do fear the long-term consequences of total body irradiation. On the other hand, as I mentioned previously, if we don't give total body irradiation, something else will have to be given. And the question is if that gives less long-term side effects. It is really difficult to get good evidence in these diseases because it's very difficult to carry out good randomized trials. The patients are very diverse, and it's a difficult group of patients to do randomized trials in. But it actually, and I think this was a major feat of the pediatric transplant group. They managed to do the Forum trial, as it's called, a large multi-center, multinational randomized trial of total body irradiation or chemotherapy conditioning in childhood acute leukemia, lymphatic leukemia. Multinational randomized non-inferiority phase 3 study where patients were randomized to conditioning either with total body irradiation or with chemo conditioning, which could be either busulfane or triosulfane conditioning. And they managed to randomize over 400 patients in that trial. I find that extremely impressive. They randomized patients with high-risk ALL over the age of 4. We are very reluctant to irradiate children less than 4 years of age. And this was an very important trial. It ran over several years. And frankly, I had really hoped that they would show that a chemo conditioning regimen would be as good. These are very sick children, and I really think they are quite difficult to. Many of them are anesthetized during all treatments, and they are so sick when they come to see us. But the results came out, were published recently. They managed to randomize more than 200 patients in either arm, and they this is the intention to treat population, and then they did proper analysis as you should, with intention to treat as the grouping, and also they did modified as treated populations to see whether that made any difference. And they did an a planned interim analysis, and that showed that the results were actually very clear. The intention to treat population analysis demonstrated clearly for overall survival that the total body irradiation containing regimen had significantly better overall survival than the chemotherapy modified chemotherapy-based regimens. And that was true in the intention to treat population. It was also true in the as treated population, where there was no difference between the two chemotherapy regimens, but they were clearly inferior to the TBI regimen. And as you can see here, for other outcome measures such as event-free survival, the number of relapses, there was a clear difference in favor of total body irradiation. And the interesting thing was that even though the outcome with regard to leukemia control was poor, there was no difference in the side effects of the two treatments. There were not fewer side effects of the chemotherapy-only regimens compared to the TBI regimens. So the trial had to be stopped before it had prematurely, but after randomizing more than 400 patients. And we have to agree, based on this very sound randomized trial, that total body irradiation is a better conditioning regimen in these high-risk acute lymphatic leukemia children, with a highly statistically significantly better outcome with total body irradiation, also in multivariate analysis where other factors were taken into account. And in fact, the only other factor that reached statistical significance was the difference between different based on age, which was just significant. So the conclusion is that TBI is now the standard treatment until we perhaps, hopefully, might get something even better. And this is the publication I'd like to, based on the FORM trial, which is, of course, a very important one in pediatric oncology and hematology. The Frontiers in Pediatric journal decided to make a special edition of their journal on acute lymphatic leukemia in children, where we were asked them to do a publication on total body irradiation in pediatric acute lymphatic leukemia. And we took the chance of actually making a very thorough review of the whole area of total body irradiation in hematopoietic stem cell transplant, with the contributions both from oncologists, but also from physicists and radiobiologists. So if you're interested and if you have a need to be updated in this area, then I would recommend this special edition of Frontiers in Pediatrics, where we have made quite an extensive review of total body irradiation in general. So by this, I'd like to thank you for your attention, and I look forward to a discussion of this topic. Thank you very much.
Thank you so much, Professor Lena Speck. That was great, from your personal experience and everything put together in these 45 minutes. Great job. We'll give you just a break for 2 minutes. You take some rest. We'll just give the answer to the quiz to the students and then come back to the Q&A session. I'll just share my screen for a minute. So this Sunday quiz that was put to you was related to 3 pictures, all having same hematological cancer, all having received the same drug, and you were asked to name the drug. And these are the 3 pictures shown to you. This lady, this hand, the back of a man. Okay. What you see exactly is depigmentation. So amounting to almost vitiligo in the 3rd picture. So this lady has got depigmentation of the skin, forehead, on the nose, on the cheek, upper part of the lip, and it's patchy all over. And what you see in the hand also, same thing. There is a depigmentation. That's the original color. And you can see the depigmentation of the palm, the proximal phalanx. And this is extensive vitiligo. That's the original color of the person. And you can appreciate this. In fact, this picture, I showed you the back and see the front, is courtesy Dr. Ankur Jain, Assistant Professor, Department of Hematology from Vardhaman Mahavir Medical College and Safdarjung Hospital, Delhi, India. And I thank him. We have used the picture published by him. We received various incorrect answers. Rituximab, ruxolitinib, hydroxyurea, tacrolimus, bleomycin, dapsone, corticosteroids, calcineurin inhibitors, and IMIDs were the various incorrect answers that we received. Good number of you have answered the first three. In fact, what you get with the hydroxyurea is darkening of the finger tips, nails, and the rest of the skin sometimes. Ruxolitinib is used for the treatment of vitiligo. So these were not the correct answers overall. The answer was imatinib, and the disease was chronic myeloid leukemia. As you know, imatinib causes patchy depigmentation, and that was the cause in all these three individuals. So this lady, this hand, and the back of this man. All this patchy loss of melanin was imatinib in CML patients. The correct answers that we received, of course, this does not include the name of the winner, between 11:45 and almost about 12 o'clock, in 15 minutes, was 6 of you. So congratulations to you for being correct, but not the fastest finger fast. Dr. Avriti Baveja, Dr. Va Arun, Dr. Naved Tamboli, Dr. Rajat Pincha, Dr. Ashwin Nair, Dr. Akanksha Gal. Congratulations to you. You at least had correct answer. And then we come to the winner, fastest finger fast, and that's Dr. Arihant Jain. So part of the minute earlier than some of you, Arihant Jain at 11:44 a.m. You know Arihant Jain. He is MD Internal Medicine, DM Clinical Hematology, Associate Professor, Department of Clinical Hematology and Medical Oncology at the prestigious PG at Chandigarh. So heartiest congratulations, Arihant, for not only being correct, but very fast. And send us your details and we will transfer the amount towards the prize that you want. Thank you. Now we come to the question and answer session. So we already have the raise hand sign from Dr. Rajan Kapoor. Go ahead, Dr. Rajan.
Good afternoon. Excellent lecture. It's always a treat listening to you, ma'am. My question is, usually we give cyclophosphamide followed by TBI. That's the commonest myeloablative conditioning. Is there an effect if we reverse the order, giving TBI followed by cyclophosphamide? Because in some institutes, it's better that, we have to send patients out for TBI. So it's administratively better that we give TBI first, followed by cyclophosphamide. Is there any difference in the effect on the outcome?
Well, I haven't tried it because we always give the TBI as really the last thing before the marrow infusion. But theoretically, the repair of damage from chemotherapy is normally more complete than repair after radiotherapy. So we always find it optimal to give the radiotherapy last, because we can do that with better repair of the damage from chemotherapy, and then the damage from the radiotherapy, some of it will be permanent, but it starts out from a better point of side effects. So in general, if you look at the long-term consequences, it is better to give the chemotherapy first and radiotherapy last. But whether that matters in this particular situation, I would not be able to tell you, because I don't know any data that have actually tested it.
Thank you.
Dr. Agarwal, you're muted.
Thank you, Rajan. And we'll take one question from the audience. Dr. Tarek Ben Othman. TBI versus chemotherapy conditioning regimen for adult ALL. The best alternative regimen in centers that have limited access to TBI.
Well, I frankly, I think the regimens vary quite a lot, and I'm not too familiar with all the different regimens that you could possibly use. So, and I think for what we do, if we cannot use TBI, we use a busulfane based regimen. But now I don't know whether there are any tests trials of other regimens.
Right. Dr. Sanket, your question.
Good evening, sir. Good evening, ma'am. It was a nice talk. My question is, for ALL, still the TBI is best, or you use flu TBI? And second question is, instead of 6 doses, 6 fractions, there are certain institutes which use 8 fraction of 1.5 gray. Does there any difference in outcome?
I couldn't quite get your first question.
Flu TBI or TBI?
Well,
TBI with cyclophosphamide or TBI with fludarabine?
Well, I think actually my transplanters, they use so many different regimens that I have actually stopped following exactly what they're doing when we use fludarabine for our reduced intensity conditioning regimens. But for the others, I think we use cytoxan mostly. And I don't know of any comparative trials that have really tested in a randomized fashion those against each other. But I leave that to my transplanters. I'm not that familiar. With regard to the fractionation, theoretically, 1.5 gray should be even more protective of long-term side effects than 2 gray fractions. I don't know of any randomized trial, and it would probably also take an awfully big randomized trial to show any difference between the two. But theoretically, giving even lower fraction sizes should protect the normal tissues. However, as I mentioned, for normal hematopoietic cells, there's very little repair. This is radiobiology, and it can be quite complex. But if there's very little repair, then there's very little difference between giving large and small fractions. And so for the normal hematopoietic cells, you can't protect them by doing small fractions. They will get the effect, the total effect, just by the total dose, because whether you give it in 2 gray fractions or 4 gray fractions, you will actually get the same tumor cell kill. For many of the normal organs like lungs and kidneys and so on, there is a very great effect of repair. And so there is a very great protective effect on these organs from giving small fractions. But unfortunately, it turns out that at least some leukemic cells do have some repair of the radiation damage. And so if you protect the normal organs by fine fractionation, you may actually also protect the leukemic cells. So that, and as I mentioned, we don't even have any good tests, genotypic tests or anything to tell us whether this particular leukemia has more or less repair. So we don't know whether it is a good or a bad idea to use small fractions for the tumor cells. I wouldn't be able to tell you whether 2 gray fractions are worse than 1.5 gray fractions. And in fact, in some patients, it would be better to use even smaller fractions if there is very little repair in the leukemia cells. However, if there is significant repair of radiation damage in the leukemia cells, you will also protect them by using even smaller fractions.
Thank you. One more question from the audience. Dr. Krishna Ratnam wants to know, what is the lower age limit for TBI in pediatric cases?
Well, for the forum trial, it was 4 years. And it is, of course, decided on an individual basis, but we certainly try not to give total body irradiation to children smaller than 4, or in special situation, perhaps 3 years. But it is quite clear that the long-term side effects are much worse the younger the child. For instance, the growth problem with growth, and also the risk of second malignancies, which is very age dependent, and it is very high in very young children. So we would try not to irradiate patients under 4 years of age.
Thank you. Dr. Deepanjan, you had a question?
Yes, sir. Thank you, madam, for the excellent talk. So you have shown about the randomized control trial in the pediatric age group, showing that TBI-based conditioning is definitely for pediatric ALL. My question is regarding adults, like whether there are any randomized trials. That is the first part of the question. Now, second part is in adults also, if TBI is better, like whether there is any comparison between high dose TBI versus low dose TBI, and what do you use in your routine practice?
Could I have the first question once more?
Madam, the first question is in adults, whether there are any randomized trials showing that TBI-based conditioning is superior to non-TBI-based conditioning for adult ALL conditioning.
Not as far as I remember. There should be an old one. But I have actually discussed this with my transplant. At one point in time, I said, because they say that the results are equal between chemo or TBI conditioning regimens. And then I asked, why do we do the TBIs then? I do think that that to some extent you can extrapolate from childhood from the children's study, and you can see that you need a very large number of patients to really show a difference. So I don't think we have any randomized trials, and I also doubt that any will be done, because what's happening is that the TBI is becoming better and better with fewer and fewer side effects because of the technological developments. Because we are much that inhomogeneity, which is clearly what we had with the old treatments, with the two-dimensional plan, with the patient sitting or what. As you can obviously see, a patient who is sitting or standing, you could never get a total body CT scan in that position. So you are not able to even control the doses that you're giving. I can tell you that when we were when we introduced our new technique, as I said, transplanters are always very, very anxious that we don't change anything because it works, and they're very scared of thinking or imagine if anything went wrong and something became worse than it was. So we tried to reconstruct our old technique where we had the patient lying on the side in the bed with lung blocks mounted on a perspex plate, and really few of us knew where they were at the end of this 20 minutes lying on the side. Anyway, when we reconstructed as best we could on a 3D planning system, what we've been doing up till then, we realized that we thought that by using lung blocks, we had reduced the dose to the lungs to 9 gray. But what we found out was that in actual fact, what we've been doing with the lung blocks was just to compensate for the air in the lungs. But in the old days, you couldn't compensate for tissue inhomogeneities. So the physicists who had originally calculated the old-fashioned, our old treatment, had thought that the lung blocks were compensating and were giving lower doses to the lungs, but they hadn't taken into account the fact that the radiation spreads much more easily in lung tissue where there's very little resistance. So when we made our new technique, because we wanted not to change anything, we did not strive to get a lower lung dose. We only strive to keep the lung dose at the lower end of the spectrum, that is minus 10% of the prescribed dose. And I think I keep saying that to colleagues from other centers still using 2D techniques, that they really need to test what they have actually been giving, because the old-fashioned dose calculations, where you actually just assume that the patient is 1 block of water and the thickness is the thickest part of the patient, they have very little idea what they were actually giving in doses. So this actually brought me a bit away from your question, but I think it's an important thing to mention to you, because if you discuss with your radiation oncologist, do make them aware that those calculations that they have actually used and thought they were giving probably doesn't fit.
Thank you, madam. The second part of my question was regarding the dosage of TBI. So the dose could be as high as 12 gray to very minimal doses. So like fludarabine, busulfan along with low dose TBI. So between the high dose versus low dose TBI, so do you think that there will be too much like difference in the efficacy in eradicating the cancer cells?
Yeah, I think that if you lower the dose below the dose we're normally using for myeloablative radiotherapy, then you would have to compensate by giving something else that will kill off the tumor cells. But also, importantly, I think a very important part of the effect of total body irradiation is the immunosuppressive effect. And so you will have to consider also that TBI is a really very, very effective immunosuppressive treatment. And this is why I also think that all the regimens for the non-myeloablative transplantations all contain TBI, because it is a very effective way of controlling the immune system. We have done actually some interesting studies on the lymphocytes, and even in ordinary, localized treatment for all other solid tumors and so on, you see a significant decline in lymphocytes, which lasts at least a year after the treatment. So irradiation has a very profound effect on the immune system, and I think that's what we are mainly exploiting in the low dose treatments, and even in the myeloablative situation. I think the immune suppression is very important, and you should consider, if you reduce the TBI, you're not just reducing a tumor killing effect, but you are reducing your immune suppression.
Thank you, madam.
Thank you, Deepanjan. One more question from the audience. Dr. Krishna Ratna wants to know, do you give cranial boost for acute lymphoblastic leukemia patients who had CNS disease?
Yes, we do it in selected situations when the transplanters consider that the risk of CNS recurrence is high. And if we do that, we will incorporate it into the whole treatment, so that we would normally give 24 gray to the brain, or as we have also been doing lately. I didn't do it before, I thought it was too much, but things are improving, and we sometimes do total craniospinal irradiation. And when we do that as part of a transplantation procedure, what we do is that we give, we consider that the 12 gray given as a total body irradiation is of course part of the treatment of the CNS. So we give what remains of it just before the total body irradiation. So we time everything so that we give the CNS radiation that will usually be another 12 gray. So we give 2 gray times 6 in the days up to the total body irradiation. So there's no break between them. So we exploit the fact that the total body irradiation also irradiates the CNS. So they will have 2 gray per day to the CNS in the days leading up to the TBI, and then they go directly into the TBI after that. It takes some logistics, but in that way we keep the side effects at a minimum, even for those patients who will have that very intensive treatment. We do the same with testicular, if they have a testicular high-risk recurrence.
Thank you. Dr. Dharma?
Ma'am, just a small question. How frequently you see late secondary breast cancer in the young girls who got the TBI?
You mean second breast cancers later on?
Yeah.
Yeah. I would not probably normally not see it, because that would we take patients from the whole of Denmark for high dose treatment, and they will not come back to us with their breast cancer, so I wouldn't know. But I would suspect that it would be quite a significant risk in the very young girls being irradiated. They are followed in long-term side effect clinics now. And so they will have surveillance at the point in time where it is considered appropriate. And fortunately, breast cancer, the prognosis of breast cancer has improved very dramatically, and particularly for the small ones. So if you find them by a surveillance program when they're very small, fortunately, the prognosis will be much better than it used to be. But I'm sure there is a significantly increased risk because we are irradiating the breast to a significant dose.
Specifically those who have positive family history.
Pardon? You mean for risk factor?
Those patients, those who have a positive family history of breast cancer.
The BRCA positive, for instance, and so on.
Yeah.
Well, we, or rather the long-term follow-up clinics, will take special precautions in families where they have an increased risk for breast cancer in the first place. But you have to remember that also increasingly we find that chemotherapy, anthracyclines, for instance, but also other drugs, to also increase the risk of second cancers. So again, I don't know what is the best trade-off in that situation.
Thank you. Thank you.
Generally, I must say that, I keep repeating that to all the patients I talk to. We talk to all of them before their treatment, that their problem is being cured of the disease that they have now, and they should not unduly speculate about a risk that will appear 15, 20 years from now, because obviously their major threat is the disease they have now.
Thank you. Thank you.
We'll go to some questions from the audience. Dr. Arun wants to know, in vivo dosimetry for fractionated TBI, is it done after completion of each fraction or at the end of total TBI dose? Any biomarkers for assessing the efficacy of delivered dose?
That is a very pertinent question, because there is some misunderstanding of in vivo dosimetry, and most non-radiation oncologists don't realize this, because we don't measure what the patient gets, what is actually made, what is actually absorbed in the patient. What is measured is the dose that comes to the patient. So what is measured is the incoming dose before it enters the patient. Ideally, and I always, argued about this, but the ideal thing would be to measure the dose coming out of the patient, so you actually knew how much energy had been deposited in the patient. But that is much smaller and much more variable, and that is not what is being measured. So what we control with our in vivo dosimetry is that the patient gets the right dose incoming. We don't measure what was actually deposited in the patient. We rely on our dose planning system to tell us that. So it is perhaps slightly some false security if you think that we have measures of what is deposited in the patient. It is a quality control of the radiotherapy.
Next one is from Dr. Arihant Jain. Who are the candidates who should be routinely offered CNS and or testicular boost in patients with acute leukemia undergoing transplant?
Well, I rely totally on what my transplanters say, and that is that, and they are very reluctant to use radiation boosts to those organs, except if the risk of recurrence is very high. So we only irradiate the CNS and the testicles in patients with having a very high risk of recurrence. Otherwise, we rely on their medical conditioning regimens, which are then obviously often more intensive. But other institutions do differently. And in many situations, like I know at Memorial Sloan Kettering, they do testicular boosts in many patients, because they say it works well, they've done that for ages and see no reason to change it. So it is also that I think is very much a local traditional or tradition that is carried forward. Our transplanters are very reluctant to give more radiotherapy than is actually needed.
Thank you. Dr. Krishna Ratnam, for acute lymphoblastic leukemia, who have not had prophylactic cranial radiotherapy, is there a need for cranial booster?
No, we not for ordinary risk patients. No, certainly not.
Dr. Arun, ALL post-transplant relapse is a prior TBI-based conditioning a contraindication for second TBI-based conditioning for the second allotransplant?
If the patient has had one high dose, that is a full dose, 12 gray total body irradiation, we will not repeat it. If the patient has just had non-myeloablative, or if the patient has had total body irradiation to the high dose, but is then a candidate for a reduced intensity conditioning, that is a mini transplant, then you can always give 2 gray. Our sort of rule of thumb is that there is always room for 2 gray more, but not 2 times high dose treatment.
Last question I have is from Dr. Arihant Jain. Any strategies in reducing the long-term radiation-associated neurocognitive dysfunction? Is there a role of prophylactic antioxidants or lithium, etc.?
Well, antioxidants are really banned from radiotherapy because, ionizing radiation works by making DNA damage. But as DNA is a very small part of the cells, it is quite rare for the ionizing radiation to actually make a direct damage to DNA. Most of the damage, we calculate about 2/3 of the radiation effect goes via the creation of radicals by splitting water, which is 70 to 80% of water. So the chance of the ionizing radiation hitting a water molecule is much, much larger. And the radicals formed, the OH minus radicals formed by splitting of a water molecule is really the main method of that radiation works in the body. And so if you give antioxidants, they are scavengers. They snap up these radicals, and by doing that, if it actually works, I don't really believe that you can really eat enough of these radicals to really make a difference, because we make them in the body all the time. But if you could, it would counteract the effect of the radiation. So we encourage patients not to take any scavengers, no antioxidants during radiotherapy, because if it works, it would counteract the effect of the treatment.
Dr. Anand Prakash wants to know, are there any specific settings where you use TBI in AML?
Oh yes, we use them in patients who are candidates for myeloablative transplants, and they would be recurrences and very high risk achieving complete remission after the first treatment, after their first induction regimen. So we I think it's about, in my clinic, about 50-50 ALL and AML of the acute leukemias for high dose transplants.
He has another question. For reconditioning, are there any settings where you use a higher dose than 2 gray?
For TBI, no, not really. We have this regimen which works well. It's also, you see, we have so many TBIs that just getting the puzzle to fit with the appointments for all these patients. And we have the low dose and the high dose, and the high dose have to have 2 treatments per day, and they have to be separated by at least 6 hours. So they run really very much as a routine, being booked in by other staff.
Right, I think that's the last question, unless the faculty present here has anything to ask, ma'am. If none, then Dr. Lena Speck, thank you so much for sparing your valuable time Sunday morning.
Well, thank you very much. It's been a pleasure, and have a good day, all of you.
Thank you. And thank you, Dr. Koito, for sparing your time and being with us to inaugurate this webinar.
Thank you very much for having me, sir.
And
I
thank
enjoyed
you,
Dr. Lena. It was an excellent talk.
Thank you.
yeah. Thanks to all the discussants, thanks to the organizing team, and thanks to the event manager. It went everything very, very smoothly. And this morning we had a very educational session. So have a wonderful day ahead. Bye-bye.